started. Well, good afternoon, everyone, and welcome to April's Fireside Chat in honor of Esophageal Cancer Awareness Month. I'm Amna Hussein, the Community Outreach and Engagement Manager at the Masonic Cancer Center, and I have the pleasure of serving as your host and moderator for our Fireside Chats each month. So the Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. The Office of Community Outreach and Engagement serves as a vital bridge between the Cancer Center and communities across the state of Minnesota and beyond. Our team is dedicated to reducing the burden of cancer by actively engaging communities and providing access to relevant knowledge on the latest in cancer research, prevention strategies, the importance of screening and early detection, treatment options, survivorship, and opportunities for clinical research. So today we are going to be turning our attention to esophageal cancer, a disease that doesn't always get the spotlight, but should. Esophageal cancer is relatively rare, but it is also very serious. And one of the greatest challenges is that it often develops silently without early symptoms, and as a result, it's frequently diagnosed at more advanced stages. However, esophageal cancer, when detected early, the chances of recovery are significantly higher, and that's why education, awareness, and early detection are so critically important. And today we have the honor of having a leading expert in the field of thoracic surgery join us today to help us unpack esophageal cancer. So please join me in welcoming Dr. Rafael Andrade, a thoracic surgeon, a researcher, the chief of the Division of Thoracic and Foregut Surgery at the University of Minnesota Medical School. In addition to his prestigious titles, Dr. Andrade is a compassionate clinician known for approaching every patient with empathy and a commitment to excellence, and really striving to provide the safest and most advanced care to every patient that he treats. He has received numerous recognitions, including being named a top doctor in thoracic surgery by the Minneapolis St. Paul magazine a few years in a row. So we are so honored to have him with us today to guide us through this important conversation on esophageal cancer. But before we dive in, I'm going to cover just a few quick housekeeping notes. Today's Fireside Chat is recorded, as they always are, and the recording will be posted on the Masonic Cancer Center's YouTube page by next week if you are interested in rewatching the recording or sharing it out with anyone who you think might benefit from the information shared. For University of Minnesota employees and spouses participating in the university's Employee Wellbeing Program, you can earn your 200 Wellbeing points for attending today's Fireside Chat by completing the form that I will be linking in the chat shortly. And lastly, please use the Q&A feature at the bottom of your Zoom screen to submit any questions or comments you have throughout our session. And we promise this time we have some time carved out at the end for a Q&A session with Dr. Andrade. And without further ado, I'm going to pass things over to Dr. Andrade. The virtual floor is all yours.
Thank you. Thank you, Ms. Hussein, for the invitation, the opportunity to share this. I'm going to share my slides. Is that showing well?
Yes, that looks perfect.
Okay. So I'll give, it's talking about esophageal cancer, like all subjects in medicine, is a very vast subject. So I'll keep it generic. I'll go into some things, and then of course, if there are more questions or questions about details and stuff, we can address those at the end during the discussion. I doubt that I'll take longer than 30 minutes, but we'll see, because I want to give time for questions. So we'll go through the definition, the epidemiology, symptoms, diagnosis and staging, treatment, prognosis, and prevention. Really, prevention I'll mention more during the epidemiology. I'll also make mention a little bit the research we have going on. So the esophagus, the esophageal cancer comes primarily in two types, adenocarcinoma and squamous cell carcinoma. And adenocarcinoma is by far more frequent, much more frequent than squamous cell carcinoma in the United States, and in many Western countries, industrialized countries. The esophagus, as you can see here, extends from the larynx, which is pretty much the Adam's apple, down to the stomach, so below the diaphragm. So you have about an inch of esophagus that's in the abdomen, and then the vast majority is in the chest, and then a little bit also in the neck. So it crosses several cavities, which then is also makes surgery more challenging for the esophagus, and we'll talk about that. So here's again a little more detail about the anatomy. This is looking from the side. So here's the larynx, the voice box, the trachea, and here's the esophagus. So the esophagus starts right here at the bottom of the larynx is a muscle. That's kind of the end of the upper digestive tract with the pharynx, and that's where the esophagus starts. And you're going to see it go down. The other challenging part about the esophagus, you can see, is very close. Is essentially not stuck, but it's just they're touching each other, this esophagus and the trachea. And it's also very close to very large blood vessels. Again, which complicates surgery some. And here's another important point about the anatomy that will be very relevant to understand esophageal cancer staging. Is this is a cross section, so like you're slicing the esophagus, and this is the inside, right, where the food would go down, and then it's got the lining of the esophagus, and it's shown crimpled because when it's collapsed, it's a little crimpled, and when it's stretched out, it kind of rounds out. And so this is what we call the mucosa or the epithelium. That's where esophageal cancer starts. And then it can work its way into the other layers of the esophagus. So there's the submucosa, which is like a fatty tissue layer, and then these are the two muscle layers of the esophageal wall, and then this outside layer is called the adventitia. It's kind of like a wrapping tissue of the esophageal wall, and I'll highlight this when we talk about staging. So there's some interesting facts about the epidemiology worldwide. So in the developing world, particularly in Middle Asia, in the Mid East, Iran, Kazakhstan, those countries in the Mid East, or Central Asia. In those countries, squamous cell carcinoma is much, much more frequent than adenocarcinoma. It's actually a very frequent type of cancer. In industrialized countries, adenocarcinoma is more common than squamous cell carcinoma, particularly in the United States, is much more common. It's also more a disease of males than females. So usually the ratio is 2 to 3 males for 1 female. And interestingly, it's an uncommon cancer. So it represents 1% of all newly diagnosed cancers in the United States, only 1%. So it's like on the 20th place of the cancers, but it's the 11th cause of cancer deaths. For being only 1% of cancers, it's responsible for it's an 11th place for esophageal for cancer deaths. So it tells you it's aggressive cancer, and a lot is to what Ms. Hossein was mentioning, that it's generally diagnosed in more advanced stages. In the developing world, as you see now, this is really key to understand when you talk about the rate of which new cancers appear in the population. They usually talk about how many cancers in 100,000 people. So you can see that the rate in the developing world, which is mostly squamous cell cancer, the rate is from between 9 and 28 per 100,000 people. And look at the rate in industrialized countries. It's about 3 in 100,000 people. So it's uh, up to tenfold more frequent in developing countries, particularly in Central Asia territory. So in the United States, it's most common in patients over 55. It's only, as I said, the 1% of all cancers, but 11th is the 11th cause of death. Usually in the US, it's a little higher than we had, so about 4 patients per 100,000 patients. And adenocarcinoma is much more common in white males, and squamous cell carcinoma is more common in African American males. This graph shows the over time, over the last 30 years, the incidence of new cancer cases and cancer deaths in the United States. And it's been decreasing slightly in the last few years, but it looks like it's mostly steady. And the 5-year relative survival, so that's of all comers, that also includes patients with stage 4 cancer, is 21%, which is not good, but there's good news coming. So what are the risk factors for squamous cell cancers? I'm going to look at the two cancers separately because although both cancers appear in the esophagus, they're quite different in many points of view. So the first, the highest risk factor, no, not now, no. The biggest risk factor for squamous cell cancer is poverty. And you can see that this is, by the way, sorry for the interruption. This is Bjorn. It's our therapy dog. And since I'm ignoring him, he wants attention. So sorry about that interruption. So the risk factors, as you can tell from the distribution of squamous cell cancer in the third world, is much more common. Poverty is just a risk factor for it. And then diet that does not contain enough fruit or vegetables is one. Geography has been suspected to be a potential cause because even in Central Asia and even without much difference in diets, just certain geographic locations have it more. Very hot drinks have been quoted as being able to cause squamous cell cancer, a very hot tea or coffee. And then, of course, carcinogens in the environment. In the industrialized world, in the first world, squamous cell cancer is much more common secondary to alcohol and tobacco, the combination of the two. And these are usually people who do both quite heavily. The risk factors for adenocarcinoma are very different. So they're esophageal reflux disease, so chronic heartburn, Barrett's esophagus, and I'll talk about that a little bit, and obesity. And interestingly, the incidence of adenocarcinoma of the esophagus in white males in the US has increased. Although the total number is relatively stable, there has been a very marked increase since the 90s, presumably because of the obesity epidemic as well. And obesity causes heartburn and GERD, and then GERD causes Barrett's esophagus, which I'll mention here in a little bit. So Barrett's esophagus is a common term, and people who have GERD, gastroesophageal reflux disease, often come to the office and say, "Oh my God, I got Barrett's and I don't want cancer." And so Barrett's is what it means is a change in the esophageal mucosa and that innermost layer that is secondary to long-term reflux. And about 5% of the US population has Barrett's esophagus. There's 1.5 million people. However, there's only 22,000 new cases of esophageal cancer a year. So we know that Barrett's does is linked to cancer and can eventually develop into cancer, but we don't have a way to predict that. And still, the incidence is very low. The people who have Barrett's, a very, very, very small percentage actually eventually progress to cancer. So now we'll talk about symptoms. So the esophagus can be obstructed to a great extent without causing much for symptoms. So you could have a tumor that's an inch in diameter in your lower esophagus, but it's not obstructing the actual inside of the esophagus that much, and you can still eat okay. Some people, particularly the people who've had long-standing reflux, might think, "Oh, it's just a little more reflux or something," and people kind of ignore the symptoms for sometimes. It's, "Oh, it's just a little funny feeling here." I sometimes feel like I got to swallow twice or drink more water, but then it goes on and on and on for weeks to months. And by the time then people seek help, then the cancer is quite advanced. And that's the most common scenario. And weight loss, for weight loss to appear, this has been going on for several months, that people start modifying their diet or just eat less. So those are the two most common symptoms. You can have other symptoms, particularly in the very advanced cancers, but those aren't specific to esophageal cancer. Those happen with any type of uh, uh, cancer. So the diagnosis is quite easy. And the most important thing is, particularly for the primary care providers, is to know someone who doesn't normally have any problem swallowing, particularly a male in his 50s that's also obese, but regardless of anyone who develops new onset swallowing problems, there's an issue. It doesn't have to be cancer, but there's a real issue, and it has to be investigated. So I would never a primary care provider should never say, "Oh, it's just okay. It'll go away," or "Let's just watch." You can say, "We'll watch it. We'll adjust your medication a little bit for 3-4 weeks." That's fine, but you can't drop it because something is going on if there's new symptoms. And the best way to find out is an endoscopy. And we do so many endoscopies anyway, so it's very low risk procedure, and it's anyone. There's no issue with insurance either because it's not a screening procedure. If someone has difficulty swallowing or new onset symptoms consistent with some food getting stuck, is no issue with the insurance to cover that endoscopy. And then you can see the tumor and you can biopsy it, and then you already have your diagnosis. And like with all cancers, once you have a diagnosis, then you have to stage the cancer. And as probably many of you know, there's a TNM international classification, T for tumor, N for lymph nodes, and M for metastases. And that's the one we use for all cancers pretty much. So to understand the staging, we have to look at this diagram. So this is, if you remember earlier, I showed you the cross section of the esophagus. And this is, this little insert is this. So here are the different layers. Here's magnified, and you can see the different layers of the esophagus. So here's just the mucosa, which is actually these three layers here. Then there's the submucosa, which is this one, which is that fatty layer. The mucosa is the lining. And then there are two muscle layers, and then there's the surrounding tissue, and then the surrounding organs. So, of course, the earliest tumors are just very in the most superficial layer of the mucosa. And those are curable 100%. Then these tumors, the T1A, so they go T1A, B, 2, 3, 4. That's how you classify the T tumors. These kind of are more like full thickness, but only within the mucosa, within this layer here. They don't pass this layer. Sorry. Then T1B tumors go into the submucosa. That's that fatty layer under the mucosa. And when that happens, that's when you start your risk of having lymph node metastases goes up, because the lymphatic channels are primarily in the submucosa. You can have lymph node metastases even here, but it'd be very unusual. So once you have a tumor that goes into submucosa, then it starts to make us think of different treatment form, and we'll go through that. Then T2 grows into the muscle. T3 grows through the full thickness of the esophageal wall. T4 grows through and into the surrounding tissues of the esophagus, but fatty tissue, stuff that you can easily remove. Now, T4 has two types. T4A, it grows into a surrounding structure, but it's a structure you can remove. So if it grows a little bit into the lung, you could just cut out the little piece of lung with the tumor. So that is still resectable. But if it grows into a structure that you cannot remove, like the aorta or the spine or the trachea, then it's an unresectable T4. So that's the progression of the different types of tumors you can have in your staging, from the earliest to the most advanced. And then the lymph node metastases, of course, if you have none, that's great. Otherwise, there are three types, depending on the number of lymph nodes you have, you classify it N1, N2, or 3. And then metastases, then it has traveled in the bloodstream, makes it stage 4. So, kind of big picture staging for adenocarcinoma is, and I'm going to talk primarily about adenocarcinoma now because that's the most common in the United States. T1 and 0, that means an early tumor with no lymph nodes. That's stage 1. Stage 2 is either T1 with a lymph node or a T2, which is a deeper tumor with no lymph nodes. And then stage 3 is a deeper tumor with a lymph node or a really big tumor, 3 or 4A, so the ones that are invading through the entire thickness or even might be invading an adjacent organ that you can remove, but without lymph nodes. And incurable, stage 4 is any of these. Now, there's some caveats to that, but that's kind of in a very big classification. And usually we draw the line, what is potentially curable? Stages 1, 2, and 3 are potentially curable. Stage 4 is considered incurable. So that's usually, we just give systemic treatment. So there's chemotherapy, immunotherapy. So for the staging, how do we stage a patient clinically, right? Because if you do an endoscopy, you just see the tumor inside of the esophagus. You can't see how much it's invading through the wall of the esophagus because you're just looking inside, and you don't know if it's invading if the lymph nodes are positive. So there are two ways to stage esophageal cancer. One is a PET scan, like in many, many cancers. And the PET scan can reveal lymph node metastases. As you can see in this view, the tumors here centered at the junction of the esophagus and the stomach. You see it here. And here you can see a lymph node. So this is already telling me that's probably an N1 disease. And the tumor is fairly sizable. So I would guess it's a T3N1 just based on this information. The other important staging information is by the time you have what we call dysphagia, the sensation of food sticking, it's often a T2 or T3 already. So that's pretty good. So if someone comes already with dysphagia, then I know, okay, this is already a little more advanced. And here's an example of a big liver metastasis seen on PET scan. Now, the other way to stage, and they complement each other, is called endoscopic ultrasound. So it's doing an endoscopy going down the esophagus, but it has an ultrasound probe too. So you can do an ultrasound of the wall of the esophagus, and then you can get an understanding of the tumor characteristics, how many layers is it invading, and you can get an understanding of are there abnormal looking lymph nodes, and you can often sample the lymph nodes to confirm whether there's cancer in those. And here you can see, this is again a diagram of the esophageal wall, the lining and all the layers. And this is what it looks like on ultrasound. And for the people who do this, they can very easily distinguish the layers. And then they can tell what type of tumor is, where the tumor, what type of is T1, 2, 3, or 4. Here, for instance, is an example of an ultrasound. You can see on this side, so this is all the esophagus surrounding, this is the endoscope with the ultrasound probe. And you can see this is normal esophageal wall, nice and thin, clear layers. And here's the cancer. So it's a very thick esophageal wall here. You don't see the layers anymore. And in this case, it's a cancer that's invading the aorta. So this is an unresectable esophageal cancer. And this is what lymph nodes look like this one here. So usually you just need those two staging modalities, PET scan and endoscopic ultrasound, or EUS. So now once you have the staging done, the importance of staging is twofold, right? One is for prognosis, and most importantly for treatment, right? How are we going to treat the different types, the different stages of the tumor? So stage 1, which is usually a very early tumor, stage 2 is usually removal of the tumor, either with endoscopy or with surgery, and I'll show you a little more. Then stage 2 and 3, that often involves either larger tumors or some lymph nodes. It's usually a combination of preoperative treatment and surgery, and I'll talk a little more. And then stage 4, which is incurable, is chemotherapy or immunotherapy, sometimes other types of therapy. So we talk about stage 1. So this is there are two options: endoscopic removal. So then naturally it would have to be a very small tumor that has not gone through the mucosa into the submucosa. So it's only in the lining. It has not gone into that fatty layer. Or if they have gone a little bit into the fatty layer, then it's surgery. So this is a diagram, schematic representation of how you resect a tumor endoscopically. So this here you can see this applies to the tumors that are entirely within the mucosal lining. So here, this line is the border of the mucosa. So anything above that, you can resect with the endoscope. Any tumor that goes past that, you may resect with the endoscope, but because of the risk of lymph node metastases, once you go into that fatty layer, it's better to do surgery. So the way they do it, they go in, they inject some saline, some fluid under the tumor where they see it, and that elevates it, makes a little bump of it. And then they can suction it, and then there's a special weight snare they put around it that cauterizes, and then they remove the whole tumor, and it leaves this little defect in the lining of the esophagus, which is no big deal. The body heals that up. Here's what it looks like on endoscopy. Here you can see this little thing is the tumor. And here it's snared. And then they cauterize and remove it. And then this is what it looks like afterwards. And then all this pink stuff is the mucosa, is the lining, and that'll grow over that fairly quickly. So this is great, a great option for very early cancers. Now, for cancers in stage 1, but that are a little more advanced, so it may be some of these if they already have a lymph node, or if we can't resect them completely, primarily if we can't resect them completely with endoscopy, and these that go into the submucosa, those are best treated with surgery if the patient can tolerate it. And surgery, the standard surgery for adenocarcinoma of the esophagus is what we call an esophagectomy, and which means removal of 2/3 to 3/4 of the esophagus, and then you fashion the stomach into a tube, because then if you remove esophagus from here to here, you end up with a gap. So to fill that gap, you turn the stomach, it's less of a bag and more, you turn it more like into a tube, and you pull it up and connect it here. So this is the representation of that. This is an example of a squamous cell cancer. The type of esophagectomy is a little different for squamous and adenocarcinoma because of where they are located. So squamous cell cancer is usually located more in the mid or upper esophagus. So then you have to remove, this diagram is not entirely correct. You still have to remove it way down here and up here. And then the stomach you fashion into a tube and you pull it all the way up and connect it there. This requires you to work in 3 body cavities. In the right chest, because to get to the esophagus, we go this way. People always think it's this way, but the heart's in the way. So if you go this way, then you have direct access to the esophagus. So you go into the chest, into the belly, and into the neck to make the connection. And we can do it all minimally invasively now. So that's one approach. For adenocarcinoma, the tumors are usually centered down here at the junction of the stomach and the esophagus. So that this is when we remove only about 2/3. And here you can see the way you fashion the tube, the stomach into a tube, is you cut off a part of the stomach when you cut the esophagus. So you're going to cut the esophagus about here, and then the stomach, it's a little more generous than this, more like here, because then the stomach will turn into this tube, and you can see here, and then we just pull it up. It's pretty flexible, it'll reach, and you connect there. These surgeries, we start in the belly and then go into the chest, also all minimally invasively. Now, for stage 2 and 3, so for very early stage 1, you just do endoscopy and remove it that way. Stage 1, without lymph nodes, or that they couldn't resect it completely with endoscopy, then we go straight to esophagectomy. Stage 2 and 3 are treated pretty much the same way, which is preoperative chemotherapy with or without radiation, depending on the protocol used by the institution, which is also known as neoadjuvant therapy. So neoadjuvant therapy means therapy you give before surgery. Then that's followed by surgery. And then afterwards, you may or may not receive immunotherapy or chemotherapy. It depends on nuances that I won't get into now. So stages 2 and 3 are these, right? So these are the tumors that either grow into the muscle or deeper, or the earlier ones that also have lymph nodes, or it can be one of these with a lymph node. So those are, but they're still considered potentially curable. Now, stage 4, I'm not showing because it's just chemotherapy or immunotherapy. There's unfortunately not much we can do at this point. Now, this graph is from a study that was just recently published from the Mayo Clinic. They looked at like 800 patients. And of course, the disadvantage of this is that treatment has changed dramatically, right? If you look over a 20-year period, they didn't do 800 in 5 years. You know, they did 800 over, I don't recall the time period. So that can influence your survival statistics, but it's what we got. So the lines are stage by stage. So early stage is stage 1, the red one. This one is stage 2, this is 3, and this is 4. This is what we call clinical stage. So clinical stage is the staging of esophageal cancer before you take it out, because there are imprecisions. Clinical stage is never as precise as pathologic stage. Pathologic stage means you've taken the thing out and you've looked at it all under the microscope. That's obviously much more precise to give you information about lymph nodes, the tumor depth, and so on. So based on clinical stage, people who get an esophagectomy, these are their survival rates. So you can see here's the 5-year mark. This was a long-term survival study. But you can see the 5-year mark for clinical stage 1. So if someone comes to the office and based on their studies, we say this patient has a clinical stage 1, then the chance of 5-year survival is 80%, which is very good for esophageal cancer. Then stage 2 is about 55%, stage 3 around 40%, and stage 4. But these are patients who had surgery, so let's not deal with stage 4. Just ignore stage 4, because most people won't have esophagectomy for stage 4. It must have been, they might have found it incidentally, and there's a very small number of patients too, as you can see. So just ignore that. So these two, 1, 2, and 3, you can see how the survival decreases. Now, based on pathologic stage, that means once you did the esophagectomy and we looked at it at the esophagus under the microscope, then you have the definitive stage. And there can be stage 0, because if these patients received neoadjuvant treatment, preoperative treatment, the tumor might be completely gone. So those are called stage 0 after surgery. Then there's again 1, 2, 3. Now, interestingly, the stage 0 patients had a lower survival, quite a bit lower survival than the stage 1 patients. Now, I have to emphasize, these are not cancer-free survivals. These are overall survivals. So it's impacted by other causes of death, which is important to know. If we looked at cancer-free survival, which I think they did not do, then it would probably be different. But you can see for stage 1, still pathologic stage 1 is still 75% survival. So that's really good. Stage 2 is this purple line. So that means these are tumor patients that already might have a lymph node positive. It's about 50%. And stage 3, and they put them together, right? Because 3A and 3C are very different. But overall, 5-year survival is about 35%. So even stage 3 is still potentially curable in about 30 to 40% of patients. And then stage 4, again, we're going to ignore those right now. Stage 3 was 25%. Stage 4 was higher, but again, very few patients. So I'm not going to pay attention to this. Stage 3, 25% 5-year survival. So it goes down, right? You have stage 1 is 75, stage 2 is 50, stage 3 is 25. But it all depends. This is retrospective data, but that kind of gives you an approximation. Now, the good news is then in the US, there are more than 80 trials going on esophageal cancer. And then there's a lot of hope that immunotherapy will also affect. We already know that immunotherapy improves the survival after surgery in patients who after surgery are stage 2 or 3. So for the patients in the purple line and then the black line, you can get very good survivals, about 50%, if you give immunotherapy after surgery. So you do neoadjuvant chemotherapy with radiation surgery, and then immunotherapy, you get a very good response and a high chance of cure. And then I'll just very briefly mention, so we have plenty of time for questions, the research we're doing at the University of Minnesota in thoracic surgery. And that's, of course, focused on the surgical aspect. As you can imagine, esophagectomy is a big deal, is a big procedure. As I said, you have to go through at least 2 body cavities to get it done. Although it's minimally invasive, still patients have complications. They're in the hospital 7-8 days, and it's a lot, and it takes a lot to get over it. People can eventually lead a normal life, but it's a lot, particularly after neoadjuvant treatment, because you still haven't fully recovered from that, and then we do surgery. So it's a lot. It's a lot. I tell patients that from the moment, if I see them in clinic before they start their neoadjuvant treatment, to the moment where they can say, okay, I think I'm done with all the treatment, is about 7 months. So it's a lot. So we're thinking of alternative ways to treat esophageal cancer, removing just the portion of the esophagus, but instead of using the stomach to reconstruct it, do a 3D bioprinting of actual esophageal tissue to fill in the gap. That's the very big picture, but that's going to be a long time away. But the way we're doing it, the concept is the following. You can take cells from the patient, and you can multiply them in the lab, and then the cells together with some other components then form the ink for the 3D bioprinting. And then you can do these constructs, you use a little ring. These are all that very early stuff we did that have those cells in it. And then you can implant it. Our idea is that the Achilles heel of this is that if you build this little esophagus with all the cells and stuff, the problem is it doesn't have blood flow. Because it relies on many little arteries, and if you just put it in like that, it'll die. But if you wrap it in the omentum is like this fatty apron that hangs from the stomach and the abdomen. If you put it in the abdomen and wrap it in there, this can promote blood vessels to grow into that construct you have. And then we can insert this new piece of esophagus into the replace the esophagus. That's the big picture. Of course, we got to start somewhere, and we've started. We're hoping to get some NIH funding. We've applied for it, and it's a joint effort between Dr. Panaskalsis Mortari and our division. And finally, you got a glimpse of the dog. This is Bjorn. He's our therapy dog. And so he comes with me to work 4 days a week, and you can see him here in the hospital rounding an ICU patient. Here's in clinic. Here is with one of our fellows. Here we're doing a bronchoscopy. He's hanging out. The nurses are all over him. And then, of course, he lets his hair down outside. Thank you very much.
Oh, I love that. Thank you so much for sharing. It was so pleasant to also see him make an appearance as well.
Yes. Yes.
But thank you so much, Dr. Andrade, for that incredibly rich and informative presentation. So now we're going to transition to Q&A. So if you haven't already submitted questions, please make sure you're using the Q&A feature at the bottom of your Zoom screen to submit any questions that you have. This is your opportunity to engage directly with Dr. Andrade. And so it's not a fireside chat for those who have tuned in before without getting our fire started. So let me just get our fire started while folks are submitting their questions. Okay.
I need a cup of hot chocolate.
Yes, something warm. I mean,
Yeah.
the weather is actually warm here in Minnesota today.
Yeah.
Definitely a nice hot beverage would be nice to complement the conversation that we're going to have now. So I guess I'll kind of just kick things off while folks are still thinking. I do see a hand raised, but we would definitely appreciate it if you could just enter in your question in the Q&A, and we'd be happy to address it through the Q&A. So let's talk about risk factors a little bit. And so we're hearing a lot about just concerns around vaping and what some of the long-term health impacts will be. Can you discuss with us today what are some of the potential links that you foresee between esophageal cancer and nicotine vaping?
Well, that's a tough one because so far most of the effects that I'm aware of vaping are in the lungs themselves. It is unclear. The problem with vaping too is that vaping can be 100 different things, right? You can vape so many different things. So it's going to be really, really hard to narrow down what's causing organ damage, whether it's the lung or the esophagus. But my suspicion is that it's going to be more an issue for the lung than for the esophagus, and the lung and the airways.
Good to know. I know it's definitely a hot topic and concern for some of the younger population that's engaging in vaping. So I'll shift gears a little bit then to more of a clinical question, and this mainly a high level overview, but what are some of the cell changes that occur in the progression of Barrett's esophagus to esophageal cancer?
So Barrett's esophagus is the presence of cells in the esophagus that are called intestinal metaplasia. They look more like intestinal cells. And that alone doesn't mean you're at risk for cancer. But a small percentage of patients with Barrett's esophagus can then start having what we call dysplastic changes in those Barrett's islands or spots. And then those dysplastic changes, dysplastic means deformed or abnormal looking cells. And there's low-grade dysplasia, there's high-grade dysplasia. And then the next step is very early adenocarcinoma. So if and the guidelines to follow patients with Barrett's esophagus, of course, vary depending on what type of Barrett's you find. And there are very clear guidelines by the American Gastroenterology Association. So having Barrett's alone doesn't mean you need to be scoped every year or so. And this sequence also takes many years to form. So I think if someone has an endoscopy done, they don't find Barrett's esophagus, then you should be pretty good. If you have Barrett's esophagus, then I defer to the gastroenterologist, but they should just follow the guidelines. They're very specific guidelines. Barrett's esophagus by itself is an enormous subject.
And actually, there's a follow-up question to that, but thank you for breaking that down. What is the percentage that can then transition from Barrett's esophagus to cancer?
If I recall correctly, and I didn't have a chance to check it, it's I would say it's probably less than 10%. It's certainly less than 10%, but I can't recall the exact number. But it's a very small proportion. However, if you take all the people with Barrett's esophagus and compare them to people without Barrett's esophagus, their risk of cancer is higher, of course, much higher than the ones without Barrett's esophagus. But it's still a very small percentage and a very small number of people who get it.
Thank you for that. So questions are coming in hot. So thank you everyone for getting your questions submitted. So you talked about poverty being a risk factor for esophageal cancer. Have there been studies that have been able to link the effects of stress as being a factor, and how can you explain to us a little bit further how stress is a risk factor, or excuse me, poverty is a risk factor, and then tying in stress to them?
So, stress is also, again, it's something that's very hard to measure, right? And all these studies, the evidence is not the greatest, right? Because these are very hard things to evaluate. I think stress contributes to pretty much any disease we have, and it make a cancer worse. I would say that I think stress probably affects it in indirect ways, right? If you're very stressed, you de-stress with alcohol and cigarettes, where that's one way, right? It's contributing. And the other one is you stressed people then get more heartburn, get more reflux, eat more, and stress leads to eating. So it's a very hard thing to discern, but it probably has an influence in this cancer and in any cancer.
So, I mean, on that note, a follow-up, what more can be done then to educate communities, especially underserved communities, about some of the risks and symptoms of esophageal cancer?
I think the single most important thing would be if an adult starts feeling that food is starting to get stuck, go see a doctor. I think because that's not normal. Sometimes we eat something too fast, so that's a different thing, right? But if it happens once, it's very different than if it starts happening and you notice a change. That's not normal. And I think that'd probably be the single most important thing for early detection. For prevention, it's very vague, right? Because, well, don't smoke, don't drink, don't eat too much. That's for every disease too.
And is there some of that provider education happening to make sure that primary care providers are thinking about esophageal cancer and that these things are not normal? So follow-up is needed. And then on the flip side of that, what can patients do then to advocate for themselves during these conversations with their primary care provider?
So, quite honestly, I don't know if there's education specifically targeted for that for primary care providers. But patients certainly can advocate and they can say, this ain't, this is not right. I need an endoscopy. We need to look into it. I need an endoscopy or something. And oftentimes it's the patients that insist and then they get the endoscopy. I think if as long as patients know that the swallowing abnormality that's not normal to have as an adult, an adult who normally was fine, um, and I would hope that most primary care physicians, I think the majority, when they hear that someone's having dysphagia, new onset dysphagia, they're pretty good about just ordering an endoscopy.
Good to know. But thank you for that. And I think the key here is that the awareness is important and then advocacy is important. So you know these symptoms, you are experiencing these symptoms, making sure that you are speaking up and sharing them with your primary care provider. So we have a question here about just what are some of the biggest challenges that patients and their families face during treatment, and what support systems do you believe make some of the biggest difference in improving outcomes and quality of life?
That's a good question. So as I mentioned, it's about a 7-month road, right?
Mhm.
That means once you're fully diagnosed and staged, it takes about 6 weeks or so to complete your chemo and your radiation. And then it takes about 6 to 8 weeks to recover from that, just to regain your strength, because that takes a lot out of you.
Mhm.
And then you have the surgery, and then it takes a good 3 months to say I'm fully recovered from surgery. So one thing, and as I mentioned, the majority are males, and males tend to be stoic about their feelings. So if I see a patient early on in that process, so before they start the chemo radiation and stuff, I mention to them that it's normal to be scared, to be depressed, uh, to not be able to sleep, be irritable and all that, because it's a very, very scary thing. And I tell them that it's okay to ask for help. It's okay to take an antidepressant for that period of time. And of course, uh, any type of help you could use, a psychologist or a counselor, anything to help you just manage that. Usually the main support system is patients' families. There are some patients, some of my patients have offered, and occasion they have talked to other patients to help them, just kind of make them know, help them understand what to expect. But it's almost impossible, right, to tell someone what they're going to feel. Um, I think, and then there's support groups you can use. I'm not aware of any of those personally, because as surgeons, we don't see that much. I think the oncologists and particularly the uh, other staff in oncology handles that much more than we do. But my impression is the families are the strongest support system. And the challenges are tough because it can be tough to work through all that period of time. Many people can't afford not working. Many people don't have good disability insurance or don't have a good support system at work. So there's so many challenges that come with it. It's a really, really hard journey. And recovering from the esophagectomy is also a really hard journey.
I think just leaning on the support system, and making sure that you are speaking up and asking for the resources and the services that you need. But I think we're going to close it out now. But to close it off on hopefully a more hopeful note, what can our audience today? What are just some of the key takeaways that you want our audience today to leave with?
I think the main ones are the ones you touched upon earlier is awareness of the symptoms, advocacy, and I think the other super important one is hope. I mean, there's always
Yes.
hope. The esophageal cancer, as the treatment success has changed significantly just alone in the last 5 or 10 years. And we have many, many, many long-term survivors. And you can lead eventually, once you go through all that, you can return to a fairly normal life and work or enjoy your life.
Okay, I love that. I think we're gonna have to end things off on that note. Well, folks, we've reached the end of our time, and I know we could continue this conversation with Dr. Andrade. So thank you so much for, staying on, engaging with us, and for submitting all of your questions. It really helped to make this conversation meaningful and dynamic. So thank you so much, and thank you, Dr. Andrade, for sharing your time with us today and expertise as well. I mean, your insights have really helped us understand, and for me personally, better understand the current state of esophageal cancer and the importance of raising awareness and advocacy and all the things that we covered. But before we go, please make sure that you take a few moments to fill out the brief survey that will auto-populate after we end the Zoom. Your feedback truly helps us improve future events. And after you submit the survey, don't close the web page just yet, because there is a link to enter into a drawing to win a prize pack filled with goodies from the Masonic Cancer Center. And be sure to join us for our next Fireside Chat in June. We're taking a break in May, but mark your calendars for June 11th for a special Fireside Chat in honor of National Cancer Survivorship Month. We are focusing on actually the caregivers. And so we'll be talking about the time burdens of caregiving with Dr. Arjan Gupta and caregiver and advocate Allison Bryinger. And lastly, follow the Masonic Cancer Center on all of our social media platforms to stay up to date on any future announcements and events from the Office of Community Outreach and Engagement. Until next time, take care, and thank you for being a part of this important conversation. Bye, everyone.
Thank you. Bye.
Bye. Thank you so much.